breast cancer has been identified as one of the most common cancers among women worldwide. It occurs in every country of the world at any age after puberty, but with increasing rates in later life. Breast cancer, tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host tonight, Dr. Debra Johnston, and we're going to be talking about breast cancer. Thank you for joining us. Breast cancer is the most common form of cancer in women, affecting approximately 1 in 8 of us in our lifetime. Regular mammograms and self-exams are key to early detection, which can greatly improve the chances of successful treatment and long-term survival. It's important to recognize any changes in your breast, such as lumps or thickening, nipple changes or discharge, skin changes like redness or dimpling, or alterations in the size or overall shape. See your doctor as soon as possible if any of these symptoms occur. This evening, we are joined in the studio by Dr. Michelle Bryan from Avera Medical Group Comprehensive Breast Care and Dr. Tiffany Torstenson from MercyOne Katzmann Breast Care. Welcome, ladies, and thank you so much for joining us this evening. Dr. Bryan, could you please tell us a little bit about your background and your work?
Sure. So I am trained as a general surgeon, and most of us are, and then did an additional year of specialty training in breast surgery. So that gives you a little bit of a well-rounded ability to discuss with patients, since you spend time with all of your colleagues in medical oncology, radiation oncology, and all the multidisciplinary time that cancer care is now. And then I've been here with Avera for about 6 years now.
Okay, and you're 100% dedicated to breast surgery.
100% dedicated to seeing
point.
breast patients, yes.
Okay.
Yes.
And Dr. Torstenson, how about you? What's your background and what's your practice?
Yeah, so I'm kind of like Dr. Bryan. I did 5 years of a general surgery residency, and then I went on at Mayo Clinic to do my 1-year breast surgical oncology fellowship, and I returned to Mercy in Des Moines and have joined my trainer, Dr. Susan Beck, and work strictly as a breast surgical oncologist now. And I'm in my 12th year.
Oh, wow. So you ladies, between the two of you, have a good 20 years of experience, so that's fabulous. We're going to get some great information tonight. Before we get started, I just want to welcome everybody. This show is not live, so you can call in, but we won't be answering any of your questions. But hopefully we will get a lot of information out to you today. So let's dive right in. Michelle, I'd like to talk about, let's start with the basics. What is breast cancer?
Sure. You know, breast cancer it's a broad term for what's a wide range of disease. So essentially, it's a breast cell somewhere has gone wrong. And that can go wrong in a small way, and it can be something that's very early and low grade, or it can go wrong kind of in a big way and be something that has mutated away and really become something more aggressively growing, almost something that really doesn't belong in the breast. So that variation is kind of what we term cancer in anything, but it's essentially a growth that doesn't belong, and if left alone will continue to grow and spread. Nowadays we have wonderful treatments, but it doesn't belong, and so that's what we do, is essentially remove it.
Fabulous. Tiffany, what are the different types of breast cancer?
Okay. So the biggest types that we deal with are ductal carcinoma or lobular carcinoma, and those all have their different subtypes, but those are the main 2 breast cancers we deal with kind of on a pathologic level. Where it really gets and where the science is really at right now is currently kind of on what we call the biomarkers, and those are are receptors we see for breast cancer. 2 of those are hormonally driven, which are your estrogen and progesterone, as well as a HER2, which is a protein we find on breast cancer. And so that's kind of where currently the research is at and the biomarkers. But the 2 main types of breast cancers are ductal or lobular, which make up our breast along with adipose tissue.
Okay, so those refer to what we think is probably the original tissue, what it was before something went wrong in that,
Correct.
Whether it was a duct or a lobular. Okay,
yes.
Excellent. Michelle, do both men and women get breast cancer? Can men get breast cancer?
They do, and people forget that. You know, by the time we see breast cancer in men, it tends to be a bit farther along, because I just think it's not something that is on people's minds. So by the time men feel it, they kind of maybe think, oh, this is something that'll go away or something along those lines. You know, male breast cancer is only going to represent 1 to 2% of the breast cancers we see, but that's still a number, and that still means men are at risk. Obviously, women predominantly are going to we just have more tissue. We have more glands, we have more lobules, we have all of those things that are turning over more with our hormonal changes through our life, so they have more chances for something to go wrong, whereas men's tissue is much less and not changing as much as ours is, but there are still chances that it can go wrong. Sometimes those people have a mutation that puts them at risk, and sometimes I've had plenty of male breast cancer patients that don't have a mutation, and it just happens.
And does that have implications for that individual's children?
So yes, any child or any family member that's had a male in their family with breast cancer should undergo genetic testing, or at least talk to a genetic counselor. Think about it, because while not everybody has a mutation, obviously there's a higher risk in something rare like that of having a mutation we can find. And then if that family member has one, they can offer testing to the rest of the family. Those family members may benefit from earlier screening, so starting much earlier to try to catch something earlier.
Anything you can catch early is always a good idea.
Absolutely.
There. So Tiffany, we talked just a little bit about genetics, particularly with men, but what are some of the other known risk factors for breast cancer?
So some of the risk factors that we kind of look at, especially when we're doing risk assessments, are, you know, when women develop periods, also when they went into menopause. We look at weight, we look at the birth of their first child, kind of the age, as well as breastfeeding. We know that's actually not a risk factor, but that goes into if a woman breastfed or did not breastfeed her children, as well as sometimes exposure to previous radiation, sometimes lymphoma. We would treat them with kind of like chest wall radiation kind of earlier when we were first treating lymphoma, so that's a risk factor. As well as any previous biopsies. You know, atypical cells put women at increased risk for breast cancer. So there is kind of a multitude of risk factors when we're assessing a woman's risk for breast cancer.
Okay. Dr. Bryan, is there a tool that you use to try to weight all that? Can you tell us a little about that?
We use a few tools. Generally, they're computer models that have allowed us to put all those in. So what you're really trying to calculate is almost a big grid. You're looking at not only their family history, but you're also looking at almost total time that they've been exposed to estrogen in their life. So if your period begins earlier, if you have more pregnancies and breastfeed, your ovaries are a little more suppressed during that time. If you have menopause at different times, so it is a lot of factors. So that is, I loved math, but that's a little beyond me. So the first calculator was very simple. It just took first degree family members, it took, just biopsies, a few things. And that gave us a rough estimate for many years, the GAL calculator. But then we learned that there's so much more subtlety to that when you really start bringing in family history. And now actually we bring in density of the tissue, and that helps us to also weigh. So when you weigh all of those, predominantly a lot of us use what's called a Tyrer-Cuzick model, and it's just a model that really has been shown to bring all those factors in working really well. Lots of other ones that our genetic counselors are very adept at using and can be very specific to certain situations, certain gene mutations, but as an overall risk, that's what most of us, I'm assuming you probably use there too, because it does all that math for us essentially.
It's nice to have computers do math for you.
It is, it is. That is, I'm not the most technological, my office will tell you, but I do appreciate those aspects.
Dr. Torstenson, is that something that I, as a woman, would have to go to you to calculate, or how would I access getting that risk calculator?
So Dr. Bryan can talk about her area too, but we do a lot of education to our family doctors here in Des Moines, and so we hold always an annual symposium here. So we really try to encourage our family doctors to kind of run these models. And then obviously they can refer them to our high-risk clinic where we can screen them a little more efficiently or provide them with some risk-reducing medicine or surgery if needed. So lots of times it starts kind of with our family doctors, but also, we run a high-risk clinic in Des Moines, and so our patients can come in and get basically those models run through our nurse practitioners. So
they're accessible and available to people.
And in our area, we have expanded on that a little bit. So almost exactly a year ago now, we implemented a program where on your screening mammogram, if it's done through any of the Avera facilities, it will actually have at the top your tyrocusic number. And is that as perfect as if somebody who has all of your information is doing it? It's not, but it is enough of an estimate to help. Family physicians get so many mammogram reports a day, and helping to flag those people who might be at high risk. So it's going to give you those people who are over 20%. And in this country, average risk is about 12%. So we set that high risk bar at going from 1 in 5 or 1 in 8 to 1 in 5 women. And so that 20% is where we set that. So that will often prompt a referral to the high risk clinic, which is the same. We would calculate out more specifically, taking a much more detailed family history and help you to know exactly where that risk falls and what that means for you.
Yeah, that has been, for me as a primary care doctor, I've sent an awful lot of people down to you guys now that I have that right in there, so that's been wonderful. And you can actually find that risk calculator online. When I first read about it, I ran my own numbers, so that was, and of course it's a little easier for me because I have a little bit more understanding of those things, but anybody can find that calculator online. And again, you're going to get a rough estimate, but it might encourage you to go see one of these ladies. So good. So what are some of the signs and symptoms that we should be looking for breast cancer? Let's talk about men first, Michelle.
Mm-hmm. So men, most commonly, it's going to be a lump. And that's just because overall they don't have a lot of breast tissue. There's less contour to the chest, obviously, so it's easier when there's less tissue there to feel something that doesn't belong. They can still have skin changes, they can still have redness. Sometimes, unfortunately, it presents even as a swelling in the armpit. That's when actually the breast cancer has spread up to the lymph nodes there, which kind of like your immune fortresses are hoping to stop it, but sometimes also become a nest for it to live in. Nipple discharge or any of those things can happen in a man, less common, but also would be concerning. So number one is if a man feels a lump that just doesn't seem to be going away, that needs to be evaluated.
And how long should he give that?
I tell anybody when they're feeling something new in the breast, give it a week or so, just to make sure it's not something weird. You hit yourself, you can get a good old bruise in the breast. We forget about, they are tissue. I like to say they're organs, not ornaments. But after that, it's worth somebody looking at. It could still be what we call a hematoma, which is a bruise. It could still be something else, an infection. I've had men with that. But you don't know, and it's worth going to your primary doctor and letting them look and say, does this look like something that might go away or not?
So Better get it checked out.
Absolutely.
How about women, Tiffany?
So women, definitely symptoms can present as a mass. Some women come in and just notice like some skin thickening, like a little dimpling, their pores look bigger. Those are more advanced cases, but we take that very serious as any redness of the skin. Some women, like Dr. Bryan says, breast cancer can start in the armpit or the axillary area. So a mass up there is always kind of a red flag to us, as well as any bloody nipple discharge. That can lots of times spell kind of more of a pre-invasive or kind of a stage 0 breast cancer when that happens. So those are kind of the symptoms. Women ask about pain. Pain is not always associated with breast cancer. We do see pain, especially when we have more advanced cases, maybe some erosion into a muscle or skin, but most of the time pain doesn't start with like a stage 1 or stage 2 breast cancer.
And I think that's a big point, is that I think people think that if something is wrong, it will hurt. Yeah. And that's not true with breast cancer. And I had a very long conversation the other day, which I'm sure you have plenty, trying to talk somebody into a mammogram. And her response was, well, if something's wrong, I'm going to know it. And I said, unfortunately, by the time you know it, you might need more than me. Yeah. And so I think more common than not, there's no symptoms, especially in women. So I think that's a perfect point, that pain is less likely often to actually be breast cancer than other benign things. And that's the concerning thing, and that's why it's so important to get mammograms.
What percentage of breast cancer can't be detected on a mammogram?
That's interesting, because you see estimates anywhere from 5 to 15%. I think it really depends. The sneakiest one, I call it, is lobular. So obviously, when you were delineating ductal versus lobular has lost one of the molecules that keeps it together. So we think of breast cancer as this lump, but sometimes it's actually these little creeping nefarious cells that can actually go throughout the lobules and be a really large area. And so those ones often aren't, but often those women will feel something that's wrong. So mammogram is wonderful, but it's also not really a way out of us knowing our own bodies and doing self-exam.
Anything to add to that, Tiffany?
Yeah, lobulars, I kind of call them the octopuses. They have all these legs that kind of go out. Whereas like a ductal is much more homogeneous. When I draw the picture, I draw kind of an octopus versus a kind of a circle for a ductal cancer. And, definitely for lobular cancers, probably Dr. Bryan, I'm 98%, I'm probably always getting an MRI on those, because I feel like we really do underestimate the size of those tumors. And so, and MRIs are such a good screening tools, which I'm sure we'll get into, but, we were talking about what cancers are missed, but MRI, especially in cancers, they change our plan about 30% of the time, and especially with lobular cancers.
So I think the take-home message there is, if you feel something different, don't think that your normal screening mammogram that you had 2 weeks ago means that you don't have to worry. We still need to check that out.
Yes, you should still be on guard and talking to your doctor and saying, I just don't feel something is right.
Yeah, so I feel something that wasn't there before. So. Genetic counseling and testing can help you understand your risk for cancer. It may personalize how you are screened for breast and other cancers, or even open up options for prevention. Prairie Doc shares one woman's experience with this tool.
As a mom, wife, and daughter, Casey Heaton wants to make sure she is around for all of life's special moments. With a history of cancer in her family, she wanted to know her genetic risk.
Started with my great aunt on my maternal mother's side, and she was diagnosed at 24 years old with breast cancer, and she passed away at 24 years old. So then my maternal grandfather, at 68 years old, was diagnosed with prostate cancer, and he passed away at 70. So then my mother, when I was 15, she decided to do the genetic testing. It showed a mutation in the BRCA2 gene.
Living in a different state at the time, when she was only 19 years old, she decided to do genetic counseling and testing.
We went to the lab, I had blood work done, non-invasive, easy peasy. A few weeks later, I got a phone call from the genetic counselor, and she said I needed to come in. Sat down with me and she said, I'm so sorry, but you are positive for the BRCA2 gene mutation.
So BRCA1 and BRCA2 are the two most common genes related to an inherited risk for breast cancer, ovarian cancer, pancreatic cancer, and prostate cancer. They're very common. About 1 in 400 people have a mutation in them. If they test positive for either a BRCA1 or a BRCA2, it can impact what surgery they might want to do. There are certain medications that can be used with those genes. It might help them with future preventative options.
Now, age 32 and living in Sioux Falls, Casey decided to take steps to help lower her risk of cancer. She made an appointment at the Avera Breast Center.
Her lifetime risk was very significant, and so she opted for risk reduction.
Casey had a prophylactic double mastectomy with reconstruction.
It's such peace of mind. Like, okay, I went from 87% chance of getting cancer to a 7%.
So I think whether a patient pursues risk reduction surgery is very patient dependent. Generally, patients have to have a pretty significant risk of developing breast cancer to really consider risk reduction surgery, because it is a big decision to go on to mastectomies with or without reconstruction. But it's really a conversation that I think high-risk patients can have with their surgeon to kind of talk through, is this an option for them?
Casey hopes sharing her story can encourage others to understand their genetic risk, and she now feels more confident in her future.
So now it's like a new chapter. It's exciting to that weight is no longer on me, and now I can just watch my babies grow and hopefully watch their babies grow.
That fit in so nicely with the conversation we were having just before we went to the roll-in. So it's just nice to see it actually in use.
Absolutely.
So, yeah. We had then started talking a little bit about mammograms and how they're not always perfect, but they are a good screening test. So what are the screening recommendations for women and for men? Tiffany?
Yeah, so there's many different task force, many different, kind of societies that recommend mammograms. And so you have to kind of take a stance on kind of what you think. At, Katzmann Breast Center, we definitely follow ACR guidelines and the ASBS guidelines.
And what are those acronyms?
So ACR stands for the American College of Radiology, and then the ASBS is American Society of Breast Surgeons. And so those are two that we really follow. And obviously, probably Dr. Bryan's a member of ASBS as well as I am. And they recommend every year, starting at the age of 40, for just regular risk, kind of that 1 in 8 women kind of at regular risk to have a mammogram every year. Some other, some task forces recommend, going every 2 years. We still feel like every year at 40, because we see so many young breast cancers. And so we definitely feel that doing a yearly mammogram is the best.
And I think those numbers are increasing of the younger women. When I started in this region, I started going out and introducing myself to some of the primary physicians, and I asked for numbers. I said, well, since there are so many recommendations and it's so confusing for people, tell me our numbers. What percentage of women here are diagnosed less than 50, which is where one of the guidelines used to be? And we had 23% of the breast cancers we were seeing. That's 1 in 5 is going to be missed. And I know we both have stories of women who've had their first mammogram at 40. I have a lovely patient who did a wonderful television episode because part of her giving back was informing other women and kind of healing through that. Found the tumor, also found her lymph nodes were already positive by that point. So I think most of us who really see this on a day in, day out feel pretty passionately about starting at 40 and every year.
Yeah. And I think, unfortunately, some of the data, breast cancer is a very curable disease, and some of the recommendations that they get these numbers from are based on overall survival, meaning how long you're going to live. But I think Dr. Bryan would agree I'd much rather catch a breast cancer at a stage 1 than stage 3, even though maybe that stage 3, the overall survival could be the same in that patient as a stage 1, but you're also not exposed to possibly chemotherapy. Possibly at a stage 1, you're going to get to avoid radiation, whereas a stage 3, your chance of more adjuvant therapies or even neoadjuvant chemotherapy is going to be more on the table versus a stage 1. So I think we miss kind of those factors in some of those studies that are representing or kind of telling us to get a mammogram every 2 years.
I think that's a good point. I think our medical oncology colleagues have amazing drugs nowadays, and we're going to get you there, right? Survival is in the 90%, but the journey is going to be very different if we find it as something very small, something where maybe you even just need us, versus if you need, chemotherapy, always the scary word to people, if you need radiation, if you need other long-term things, many other drugs they have. So while yes, again, the endpoint is often the same, not always. There are some breast cancers that the endpoint is actually very different. When you have those very aggressive breast cancers, if you find them at a stage 1 versus a stage 3, for example, the ones not driven by your hormones, that actually even changes the survival. So that's why I think we feel so passionately that while some of those numbers are based on overall, there are so many caveats to that starting there makes so much sense.
And if I knew what kind of breast cancer I was going to have in the first place, that would sure help, but you don't know which one you're going to get.
That's the roll of the dice.
Yes. And how about men? Are there any screening recommendations for men?
So really there aren't great screening recommendations for men because they do represent such a small population. Any man should be self-aware of that tissue and just looking. Most of the time the expectation is that when you're doing a chest exam, even when you're doing lungs, any of those, that as you're at least seeing the chest as a primary doctor, because often in men you can see the tumor if you look, depending on how that man is built. But there aren't recommendations other than that until you get into kind of genetic mutations and things along those lines.
Okay. Anything to add there, Tiffany?
No, I think that's, I feel like, I do see probably, 1 to 3 men every year. Yeah. And, it's usually in the circumareolar, area where lots of times they come in a little more advanced or they notice nipple changes. But, there really isn't great screening guidelines for men. I mean, I think the biggest things is self-awareness. If there's a family history or genetic mutations, there's some ways around there where we can get them screened a little bit. But I feel kind of we leave them out of some of these talks when actually, you do see these men, and sometimes I think they ask for answers and there's just not lots of data backing up kind of breast cancer in males.
We talk a lot about how women are underrepresented in medical research, but this is one area where the men are maybe underrepresented. So let's talk through some of the tests that we do use to diagnose breast cancer. We've talked about the mammograms. We've talked a little bit about MRIs. Is there anything else, Tiffany, that we might use to diagnose a breast cancer?
So there are some nuclear medicine studies. I don't know, Dr. Bryan, if you guys do those kind of at Mayo. Sometimes they do some nuclear medicine mammography, where it's a kind of a contrast study, kind of a nuclear medicine injection. They do some of those mammograms. We just do 3D mammograms, which have definitely been shown to pick up smaller cancers. We do ultrasounds, obviously, but we don't usually do those as a screening tool. And then kind of MRI, especially in diagnostic purposes for cancers. But we also use MRIs for women who have a risk factor of over 20% lifetime risk to get breast cancer. But most what we do in Des Moines are usually just the ultrasounds, mammograms, MRIs. But there are other things, like I said, kind of nuclear medicine studies that you can find.
We also use a lot of contrast mammogram. So whenever you're looking at a mammogram, you're looking at that tissue, and we make something out of density. So that's something that's always this word that gets thrown around, and it's really confusing because what exactly does that mean? Well, probably that density itself conveys a little bit of risk, but more importantly is density is how white is your mammogram. Right? How, a normal mammogram looks very black. So when you're looking for a cancer, it's white. So our eyes are drawn to contrast. And so I always show women their mammograms, and if they have a lot of dense tissue, I said, well, this is the snowstorm we're now looking for a snowball in. Right? So it's tough. So the tools that we use are things that, whether it's nuclear medicine, we don't really use that anymore. Whether you use MRI, you're getting a contrast, and contrast by word is, again, it's going to pull out differences in the tissue. Or something we use is a contrast mammogram that actually uses CT contrast to accomplish the same thing, but in a mammogram setting. So for some women, laying in an MRI machine is just not feasible. Mm-hmm. If you've had a breast MRI, it takes a little bit of doing, laying there very still. There's some women who can't get one, who have implanted devices, different things. So having a broad range of things, and things that, we talked a little bit about meeting people where they are before when we were talking. Sometimes I say, well, this is what I really want you to do, and from either a cost perspective, from a comfort, any of those, that's not something they can do. So that's where these other things that are still giving that visual, that difference in the contrast are helpful. So I love using contrast MRI or mammogram in a lot of those. Some places have more abbreviated MRIs that they can get you in and out a little bit shorter time, but still get enough images from a traditional that's really going to give us the best information as a surgeon for planning and definition, to almost a little shorter that women can put up with as a screening when they're higher risk. So I think we have a decent number of tools, but we're both saying that it starts with a mammogram, though. There's no substitute for a mammogram, and then these are our adjunct tools on top that are going to help us define things.
Tiffany, sometimes I have patients who tell me they're doing thermography. What do you think about that? What should they know?
That's a tough one. So usually I tell them when they say, oh, I have kind of a hot spot, and I said, okay, well, let's go look at that hot spot under a mammogram and an ultrasound. And so, there is a lots of kind of alternative therapies, and, I'm very open to those, and very respectful of those, because I think there are some things we can learn from, but kind of like Dr. Bryan, it always comes down to, we've got to start with a mammogram. That's where we have to have the baseline, and we can kind of use adjuvant studies, but the baseline kind of standard of care is to start with a mammogram, because I'm not trained in reading thermograms, and I've looked at them, but I still always send them over if they're willing to go get a mammogram to start with.
And the basis of the thermogram is that you have to have a change in blood flow, right? That heat comes from increased blood flow. Well, in our world, by the time you've made new vessels to that tumor, I always tell patients the cat's out of the bag. And so that is not the same as a mammogram in terms of early detection. And a lot of the studies they're going to cite for those are really in regions of the world that they don't have the capacity. We are so blessed here. I mean, we can get a 3D mammogram anywhere we go. Even within this country, I was amazed. When I came to South Dakota, when I first started practicing, I said, okay, how much is the cost to my patient for an upgrade to a 3D mammogram? And They said, we don't know what you're talking about. Everybody had 3D mammograms in South Dakota, and there was no cost upgrade like there was where I was. So, this technology has taken off to the point that we have wonderful mammograms. Is it fun? No. I go get squished once a year. But
we all do. All three of us practice what we preach.
Exactly. So I'm not saying it's something that I am super excited about, but it's something that you do knowing that the alternative is so much worse.
So the thermography is not going to catch things as early as a mammogram is, so it is not the same as your screening mammogram. So it's not a good substitute is the take-home message.
Yes.
So good. The Rapunzel Project is a nonprofit dedicated to creating awareness around cold cap therapy. Prairie Doc spoke with Nancy Marshall, one of the co-founders of the Rapunzel Project, about the organization.
You apply a very cold cap to the head. That cap constricts the blood vessels that lead to the hair follicles. And because the cap's extremely cold, it also slows down the metabolic activity of those cells. Chemotherapy is administered through the circulatory system. So if you constrict the blood vessels, very little chemo gets through during that period of time that everything's so cold. And furthermore, even that chemo that does get through tends to get processed very slowly because the cells are pretty sleepy because it's so cold. As a result, chemo drugs are not really administered to the hair follicles for the period of time while the capping is ongoing. So if you have those caps on for 4 or 5 hours after the infusion is finished, by the time you take those caps off and everything starts to warm up again, the drugs are considerably weaker than they were at the moment of being administered. As a result, most hair follicles can apparently withstand the dose that reaches them at that point in time.
Marshall, along with her close friend and business partner, Shirley Billingmeyer, are both breast cancer survivors. When Billingmeyer was diagnosed with breast cancer, they heard about the topic of cold capping and its positive outcomes for patients.
She had had 2 treatments. It had been 6 weeks. Her hair should have been 100% gone. And that morning at 8 o'clock when the clinic opened and we walked in, the whole staff was lined up like a receiving line. And when Shirley walked in with a full head of hair, there were people crying because they truly thought we were crazy, justifiably so. They were like, if this treatment worked, we'd know about it. The doctors would know about it. People would be using it. No one had ever heard of it. No one thought it would work. And Shirley had a full head of hair.
From there, the two decided others needed to be informed about the treatment, and in January of 2010, the Rapunzel Project was born.
We never dreamed that 15 years in, we would still be needing to do this, but we are still needing to do this. It is widely known in some areas, particularly New York and LA, Florida. It's less widely known, but not unheard of in other places. And there are parts of the country where it's a dark secret. It's not about dignity. You're as dignified if you're bald as if you have a full head of hair. But it is about identity. It's looking in the mirror and seeing yourself and not a stranger.
It's so exciting to hear about these new things and how we're improving the quality of life for people that are undergoing treatment and are survivors. So that's really exciting. Michelle, are there people that would not be good candidates for that therapy?
For the cold
cap therapy, yeah.
Cold cap is absolutely wonderful, but there are different versions of it. Some of them are quite labor intensive. So my experience, and maybe Tiffany can talk about hers, is we're not the medical oncologists, we're not the ones giving the chemo, but I see patients at intervals and I see them at the beginning and end. There are a lot of rules And sometimes you have to have a support person changing out depending on which one you use, ice packs every couple hours, things like that. I think a person who goes into it thinking, maybe this is for me, it's probably not for them. You have to go into it knowing that there are certain rules about brushing your hair. There's certain rules about, washing your hair during this. But if you go into it with that mindset that this is really important to me and I'm going to follow all these rules and work with it, then absolutely it could be something for you. But I think the biggest thing is there's not a specific person, because the cap doesn't have a size cutoff or anything like that, but there's a personality and there's an importance of that. For some people, I had a patient who got married during her treatment. That was really important to her, to look back on her photos, and not really even from a vanity, but from every time you look at your wedding photo, is your breast cancer journey what you want to think of, right? You want to just think of that, and your breast cancer journey is this other part of your life. So for some people, though, that is an amazing game changer.
Anything to add, Tiffany?
Yeah, I think sometimes the scariest part when we mention chemo is, we can talk about the side effects, but I think what it gets women is like, you will lose your hair. And I mean, that's when I see most of the tears come, and so your hair is a huge part of your identity, and it's not vanity, it's more femininity, and I do talk about cold capping, and we do that, but it is very laborious. I had a 30-year-old that was extremely important to her. She has very young kids, and I got her set up, and like Dr. Bryan said, it's mostly through the medical oncologist, but when a woman mentions it to me or I throw it out there, we kind of tell the medical oncologist, because they help with that, because it's a very long process and it's a very hard process. It's having that cap on, getting dry ice, and you have to have another person there to support you in this. And it's amazing though, because she came back and she looked awesome, but it's not a one size fits all, but it's taking, it is a lots of work, and some women, this diagnosis is enough that, they can't do it, but it's definitely possible if they understand what it takes. But I think it's a great option for women that really want to keep their hair.
I think that's a big point too. For some people, it's just they don't want to have the conversation every time they're somewhere. And it is interesting how far wigs have come, because we always think of those kind of bouffant, or we think of, I don't know, I'm dating myself, but the Barbie doll with the head or things like that I used to play with. But I've had patients who also have amazing wigs too, and the wig programs that most cancer centers like ours are going to be awesome too. So cold capping is a wonderful thing, and it is a great tool for some people. But there are alternatives, and we can help with some of those things. I know, through Avera, we have a foundation that helps with those wigs, and just the fact that, again, you're looking back and maybe not always having to have that conversation every time you walk into a grocery store of, oh gosh, she must have cancer, right? It is, something that makes life during that time just a little bit easier sometimes.
So lots of options for women and men.
Absolutely.
So something.
I don't have a lot of takers from the men on the wigs.
Yeah.
Usually they're good with going bald and being comfortable with that. But
But it's nice to know that there's options
Absolutely.
out there for people. Well, this has been a great conversation, and we've got a lot more things that I'd like us to be able to talk about, and we don't have a lot of time left. So one thing we've mentioned a couple of times here already, when people talk about breast cancer, they talk about stage 1, 2, 3, 4. What do those stages mean? Tiffany, can you give us a quick overview?
Yes. Definitely. So I'll start with the bottom up. We'll start from worst to best. So stage 4, that is what we consider kind of incurable cancer. So that means it has to have spread distally. And kind of just to talk about metastasis, there's different types of metastasis. There's kind of local regional, meaning to kind of the lymph nodes, and then there's distal metastasis, and that is to like a different organ. That's to the bone, the brain, the liver, and lung. And we do consider that incurable, and in most cases not a surgical candidate, but many women, do very well with stage 4 breast cancer. It's one of the few cancers that women can live 20 to 30 years, depending on kind of the biomarkers and what therapies with medical oncology. So some women, that stage 4 is very scary for them, but actually they're doing quite well. But most of the time we don't consider that a curable stage. Stage 3, those are lots of times more are aggressive types of breast cancer. Those are kind of our cancers where you hear about inflammatory breast cancer. Lots of our triple negatives, if they spread to the nodes, are kind of in that stage 3 breast cancer. And so those types of cancers are larger cancers, or they have skin involvement, or they have lots of lymph nodes that are kind of involved in that. And those are the cancers that definitely we will probably most likely send to chemotherapy first, that will probably get radiation, not necessarily always a breast removal, but definitely more adjuvant therapies in terms of radiation and chemotherapy. And then the stage 1 and stage 2 breast cancer, those are very curable breast cancers, 5-year survival rates, usually over 90 to 95%. Those are the cancers that, we want to see, or we want, to get picked up by your mammograms. And those two still can have nodal involvement, and they can still be big cancers depending on their biomarkers. Again, estrogen, progesterone positivity are what we like to see more than having those biomarkers negative. But those are usually the cancers where we can take them to surgery first. We don't need chemotherapy to shrink them. And then even some stage 1 breast cancers, we're avoiding radiation. And sometimes in our older patients, we're even avoiding doing any nodal surgery in those early stage 1 or favorable breast cancers. So those are kind of the stages in a nutshell.
Anything to add, Michelle?
No, I think part of it is tumor, part of it's lymph nodes, but so much of it nowadays is really getting down to this personalized, what is the tumor actually doing, what is the biology. So that's, the staging system has changed so much over the years, and now, the tumor, the lymph nodes are a part of it, but I think we both agree that you can have really large tumors that are very, what we call, well-behaved. And so that's the point, is that sometimes women just automatically come in and are so scared by what we're telling them. They sometimes actually fixate on, well, what's my stage? And I say, well, your stage doesn't matter as much to us, because really 1 through 3 are a group here, and we're going to do this because they're curable. Stage 4, again, not curable, but very treatable. So I think the biggest thing is now partially the stage, but also partially just targeting based on what are those cells doing. And that's where the science and everything continues to advance and give our medical oncologists those tools to target each of those areas, even within a stage.
Fabulous. We've heard a lot in the lay press about lumpectomies versus mastectomies. Is everyone a candidate for a lumpectomy for breast conserving therapy? Tiffany? Yep.
Yeah, so, in our practice, we looked at our numbers last for our certification. We had 30% of mastectomies versus 70% of lumpectomies. And so we really try to push for breast preservation. If I can get a woman there to save her breast, kind of like Dr. Bryan, it's an organ. Why remove an organ? And it comes down to kind of just the medical data. We know that based on what kind of the markers we look at, as recurrence rates and overall survival. And we know women who have a lumpectomy, usually followed with radiation, the overall survival and recurrence rates versus a mastectomy are not statistically significant, So I always tell that woman who comes in and she hears a cancer diagnosis and she's like, Dr. T, I just want them both off. And I'm like, okay, slow down, let's talk about that, because you don't need to really lose your breast, and you're not going to gain something medically for that. Again, you always have to take in family history, age, the genetics, but we hopefully can always offer our women a lumpectomy. I mean, granted, sometimes if the tumor is too big and they're not a good candidate for neoadjuvant to shrink, that there's definitely other factors. But my first intention when I'm thinking of surgical is how can I get this woman to hopefully keep her breast, and we are even saving breasts for 2 and sometimes up to 3 tumors in the breast, depending on the breast to tumor ratio. And then we bring in like oncoplastics, which a lot of times we work with our surgeons to try to save that breast and possibly reduce the other if there's going to be. So we are very pro preservation in our clinic, and I'm sure Dr. Bryan would probably say the same thing.
Absolutely. I think we both probably should keep numbers of how many women come in and, okay, take them off. Exactly. We hear that every day. And I say, absolutely, I can do that. I love to do surgery. But let me tell you some numbers and what you are and are not gaining. And so, yes, we're going to work to try to preserve the breast if we can, but there's some physics to that, and there's some just basic spatial things, which is if the tumor is bigger than the rest of the tissue I have to put together, then that's just not going to work out. Although we really do push that envelope together with our plastic surgeons, and that's what the oncoplastics is the oncology, and then working with our plastic surgeons who are just experts at looking at something and figuring out how to rearrange it. There's so many rules to how you can rearrange it based on what the body gives us in terms of anatomy, blood supply. But there are women coming back to that who can't get a lumpectomy just from a basic, it won't work to put that tissue back together. But the vast majority of women can. That doesn't mean that they don't have a choice for a mastectomy still, and there's so many factors that go into that. Sometimes it's family history. If somebody tells me mom and grandmother and everybody had it, that worries me. I tell them, I can't make your risk 0 with mastectomies. I can reduce it. And I think that's a misnomer that people have, and especially the people telling them, just take them off. Well, that doesn't guarantee breast cancer won't come back. At best, we get 90 to 95% of the breast tissue. So there are always breast cells left.
So it's really important to personalize that and to have that conversation with your breast surgeon.
Absolutely.
Fabulous. Thank you so much, ladies. We'll be back after this.
Grab a copy of your local newspaper or read online the Prairie Doc Perspective, a weekly health and medical column. Head to prairiedoc.org to access all archived columns today.
Thank you to our guests, Dr. Bryan and Dr. Torstenson, for volunteering their time to help us learn more about breast cancer. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online, and listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for a podcast of this program, Prairie Doc on Call, wherever podcasts can be found. Thank you again, ladies. This was great. From all of us here on Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Parkinson's disease is a progressive disorder that affects the nervous system and the parts of the body controlled by the nerves. Although Parkinson's can't be cured, medicines might significantly improve symptoms. Understanding Parkinson's, next time on Call with the Prairie Doc.
My name is Dr. Tad Jacobs, and I serve on the Healing Words Foundation, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,